again you can put a scale or something and measure the height from this point. So basically, the angle is just a matter of convenience, and the usual jugular venous pressure is around 8 centimeters above the central point of the atria, or around 3 centimeters above the sternal angle. So that is the way we see. So the initially to the jugular venous pulse, because basically this is a visual appearance of the pulse, of the venous pulse. So the normal jugular venous pulse has these waveforms. The A is because of the atrial contraction. The C is because of the ventricular contraction. When the ventricle contracts, the atrioventricular leaflets bulge into the atria. And then the X dash descent, the main X descent, is because of the ventricular systole. There is this sharp, rapid filling wave, then the slow filling wave, and towards the end of the diastole, again the A wave. So this is the basic thing about the jugular venous pulse. Now the problem is, many times what we are seeing is actually the carotid pulsation. So the easy ways to look into it is, like one I said, the first maneuver is to make the person sit up and lie down, so that you can actually see that it is vanishing and coming back again, jugular venous pulses. And that is why you have this shunting in the ASD, and even in the ASDs, the main shunting from the left to right atria is in systole. That is because the valve rings, that is when the flow actually happens. So these are the pressures, and as you can see, the jugular venous pressure as a marker of LV filling pressure. We are not talking about RV, we are talking about LV filling pressures. So the right side as a marker of LV filling pressures, as you can see, the sensitivity and specificity is pretty good. That is why it is such an important thing for bedside examination for all clinicians. If you look at heart failure, you all know the wet types and the cold types. So one of the main things in the wet types are the jugular venous pulse, the hepatojugular reflux, and the Valsalva square wave in the BP, the response of the blood pressure. So these are the three waves, these are the three maneuvers, are the things that we look at to confirm that the person has heart failure. Now, which one is which wave? It's usually pretty easy. If you are feeling the pulse, just after the pulse or with the pulse will be the V wave. So it depends on you if you are looking at the peaks or you're looking at the troughs. So if you are looking at the trough or the fall that happens just onto your pulse is the X descent. If you are looking at the peak, then the pulse, if you're looking at the pulse, that is the just after the pulse or corresponding with the pulse, the peak wave is the V wave. Similarly, if you're looking at the A wave, just before the S1, if you're auscultating just before the S1, or you will see the A wave. So it depends on whether you are timing it with the pulse or whether you are timing it with your heart sounds, but it's pretty easy to make out which wave is which once you know that it is the JVP. And usually on the A wave and the X descent are bigger than the V wave and the Y descent, and these are brief and the falls are sharp. So usually the wave the fall that you see, usually you are able to appreciate the falls better than the peak wave. So the falls that you see is usually the X wave, which is the most prominent one. Now the left atrial and the right atrial pressure forms are different. As you can see, the left atrial, the V waves are the bigger ones. So the X descent is not the bigger one. Usually that is because the left atrial compliance is much less than the right atrial compliance. So that is why you have these large shunts in ASD. Although the pressure difference is less, the compliance is different between the left atrium and the right atrium. So it is not just the pressure, the compliance also has a huge part in the filling characteristics of the heart chambers. Now if we look at the waveforms, so where do we get this large A or the atrial systolic, you can say the waveforms here. See, you will get in tricuspid stenosis when the valve is not allowing the blood flow, or the right atrial myxoma when it is, it is filling in the cavity, or in diastolic dysfunction of the right ventricle. Just like you get diastolic dysfunction of the left, when you have diastolic dysfunction of the right ventricle, which could be a part along with the left, or could be more manifest in pulmonary artery hypertension or pulmonary stenosis, you might get a larger A wave. And if you have sinus tachycardia also, because the A wave will come on to the nearer and nearer to the V wave, then also you will get larger A waves. Now, when do you get an absent A wave or an absent X descent? When you don't have atrial beats or atrial contractions like atrial standstill or atrial fibrillation, you don't see those waves. And also in RV dysfunction, because the tricuspid valve has to be pulled down to produce this descent. So if the RV is dysfunctional, then especially when it becomes a restrictive phase, you will get sharp Y descents, but the X descent will vanish. And also it happens in loss of pericardium, because the pericardium has to be intact, because when the ventricle contracts, there is negative pressure in the pericardium that is transmitted to the right atrium. So that produces this waveform. So once that is lost, that descent is also gone. So when do you get a sharp X descent? In atrial septal defect, we'll talk about it later. In pulmonary stenosis or pulmonary artery hypertension, like I said, the A wave is bigger, and also the RV contracts hard against the pressure. So you get this large descents because of the large descent of the AV ring. And also in the tamponade, which we will discuss later, which is a very characteristic finding. So if you get a large X descent in a person who has a raised JVP, you have to think of a tamponade. And then the increased V wave. When do you get this increased V wave? This is the systolic ventricular filling wave, which means during the ventricular filling, the atria is being filled. During the ventricular systole, the atria is being filled. That is the V wave. So whenever you get rapid filling or more filling, like in hyperthyroidism, anemia, anxiety, exercise, you get large V waves. Or when you get more filling from the other chamber, like in ASD or anomalous pulmonary venous connection, or when there is a PFO and severe MR, when the left atrial blood is coming into the right, then also you get it. And also very characteristically, you get it in heart failure and in constrictive pericarditis, and whenever there is a decreased X. So if there is a decreased X descent, like in heart failure, then naturally the V wave will become bigger. So it is like that. So in heart failure, the prominent wave that you get is the V wave, and when it gets very restrictive, you get a very sharp Y descent, just like in constrictive pericarditis or just like in constrictive pericarditis. So we'll talk about special situations, ASD. In the atrial septal defect, as you know, 3 or 4 things happen. Number one, the atria is sort of overfilled. So when the atria contracts, you get a large A wave. And then once the ventricle starts contracting, you get a very rapid and good descent of the AV ring towards the RV apex, because the RV has to pump hard to push out all that blood. And then there is, of course, an increased input into the right atrium, both from the systemic venous circulation as well as from the left atrium. And that's why you get a large V wave, and then, of course, a descent. So you get these things, both large waves are there and the descents are not sharp. Whereas in constrictive pericarditis, you also get large waves, but the descents are very sharp. So here it looks like, you are able to perceive the bigger waves. Here, the pressure is more, definitely much more than in an ASD, and you are able to perceive the descents more than the waves, more than the ascents actually. So this is the difference. Here in constrictive pericarditis, you will see that it is the more of a descent, whereas in the ASDs, you nicely see the positive waves. So the most important thing is the pericardial tamponade and constrictive pericarditis. Now in tamponade, what happens, the basic problem is the diastolic flow is restricted throughout diastole, and the entire forward flow into the heart happens in systole. And the cardiac output is mainly maintained therefore by tachycardia and increasing the ejection fraction. That's why you get so much tachycardia in tamponade, because the whole forward flow is being limited to the systole when the AV valves are descending. So that is the only way the heart fills well. So because of that, it has to produce a lot of tachycardia because the ventricles are underfilled. And that, because of that, you get a large X descent. So the X descent is because the forward flow in tamponade is mainly because of the descent of the AV rings. And then there is hardly any Y descent, because as you know, there is limitation of the diastolic filling all throughout the cycles in tamponade. So there's hardly any Y, and there's a rapid X. So you basically see only a rapid X in tamponade. In constrictive pericarditis, what happens is there is rapid filling. The initial part, there's a rapid filling, and then there is a square wave response in the ventricles. So once it is filled, the filling is obstructed because of the shell of the pericardium, and then it rapidly rises up and you get a H wave. So in the JVP also you get something called the H wave, which corresponds to the plateau phase of the left ventricular or the right ventricular filling pressures. And you get a X wave also because the ventricle has to contract hard, pulling down the AV valve rings, because that is one way it maintains cardiac output even in constrictive pericarditis. So in constrictive pericarditis, we get both these waveforms, whereas in tamponade, you get mainly only the X. Now in severe mitral regurgitation or aortic regurgitation, also long-standing regurgitations, because the left ventricle dilates and the septum is pushed towards the right ventricle, you get what is called Nims effect, which somewhat simulates constriction. So here also you can get this deep X and Y descents. So we will come to some special situations like AFib. In atrial fibrillation, there is really no A wave, and so the X descent is very small unless there is tamponade. So unless there is tamponade, it looks very small, and then there's a large Y descent. So this looks somewhat like a tricuspid regurgitation picture. So you can see the tricuspid regurgitation picture is like this. As you can see, what happens, more the tricuspid regurgitation, more the systolic V wave, because the blood actually, instead of the RV, instead of the RA, is filling both from the venous side as well as from the ventricular side in systole. So you get this large systolic V waves and then a big descent. So you get waveforms similar to tricuspid regurgitation waveforms in atrial fibrillation. So basically no A waves, poor RV contraction, like the AV valve rings are not pulled down rapidly. So this descent, the X descent is almost not seen. Increased right atrial pressures and some tricuspid regurgitation. So all these things put together give rise to the larger V valves and the sharp Y descent, which mimics tricuspid regurgitation. Heart blocks, of course, you all know. You get these Canon A waves, which are really not seen well. but you can actually feel some of them well. So Canon A waves, unlike it might be difficult to see because many of them go intracranially. So these are the different waveforms that you see. Tricuspid regurgitation, you call this the systolic wave, which sort of corresponds with your carotid pulse. So there's a large jugular venous pulsation corresponding with the carotid pulse. And then in constrictive pericarditis, the JVP is elevated. You get rope-like veins, and you see the sharp descents rather than the ascents. In atrial fibrillation, you get irregular waveforms, especially if there is flutter, and then you get these descents again, just like in the tricuspid regurgitation. And then in tricuspid stenosis, you get these larger A forms, A waves, which correspond with the first heart sound somewhere. So you get these large A waves, and the Y descent is very poor. ASD, you get this, both these waveforms are large, and in complete AV block, you get these Canon waves. So we'll talk about hepatojugular reflux, which is one of the three main important points for a bedside diagnosis of heart failure. So one is the jugular venous pressure. The other one is a hepatojugular reflux. What happens is when you give a constant pressure on the abdomen, normally there is a tourniquet effect that limits the inflow from the leg veins into the heart. So normally the pressure, jugular venous pressure, should not increase at least. But here what happens is, there is actually, when you press the abdomen, some of the blood sort of regurgitates into the superior vena cava. And then what happens, the jugular venous, you press this for more than 10 seconds and the jugular venous pressure increases more than 1 centimeter, usually around 3 centimeters, and remains so for at least 15 seconds after release. So there is some controversy about how long it should last. The longer it lasts after you release, it means the more severe is the heart failure and more the sympathetic tone of this person. So many times the jugular venous pulsations, the pressure will normalize after you use diuretics. But even then, when you try this hepatojugular reflux, you will see that the JVP nicely increases. Of course, you should see that you do not cause any pain to the patient while pressing the abdomen, because that will increase the sympathetic tone and give a false of HOCMs. Basically, whenever you get an extra systolic, whenever you get a PVC, the next beat, because there is an increased outflow obstruction, you actually the pulse pressure decreases, and this is called the Brockenberg effect, and is seen in 1/3 of patients with HOCM when you're palpating the pulse. And a similar thing happens in constrictive pericarditis also. It does not decrease, but it does not increase because the increased diastole is unable to fill the ventricle, because anyway the ventricles fill only in the short rapid diastolic phase. So increased diastole doesn't mean that it fills more. So you do not get a bigger pulse after the pause of the ectopic, even in a constrictive pericarditis. Pulses alternans, again, it is a sign of heart failure along with obstruction or resistance to outflow. So it is usually found in atherosclerosis, aortic stenosis, and coronary artery disease. So unlike dichrotic pulse, you see this with increased age also. So dichrotic pulse is when the aorta gets stiff. You may not be able to see this, but this you will get it even if the aorta is stiff. Sometimes there may be total alternance, which means you don't get a pulse at all. You might get auscultatory alternance of the heart sound. Many times it is actually associated with T-wave alternance also, very peculiarly, and that's a sign of very poor prognosis. And it disappears with treatment of heart failure, so that when you unload the LV, it might disappear, and you have to differentially diagnose it from pulses bigeminy, which is because of the ectopic. So you have to get a regular, absolutely regular pulse to diagnose this pulses alternans. It is a very bad prognostic sign, both the dichrotic pulse and the pulses alternans. So we have discussed all these pulses. It's a pretty easy thing once we know and once we start doing it. Although the actual yield is not as high as we think, but it is always good to check this at the bedside. Then comes the pulses paradoxes, which is most probably the most important thing. Most of you know what is the genesis of the pulses paradoxes. Two things happen when the person inspires. More of the blood accumulates in the pulmonary circuit, so there is less going into the LV. And then because of the tamponade, there is more ventricular interdependence, so that when the LV fills more and the LV fills less during inspiration, because of more blood getting accumulated in the pulmonary circuit, and the RV fills more, then what happens is the LV filling is decreased because of this accentuation of the interventricular dependence, because of the it is more in so this produces a drop in the blood pressure and in the pulse also sometimes during inspiration. So this happens normally also. So when it is more than 10 millimeters, you call it pulses paradoxes. So as you can see here, the nice diagram, the forward flow pressures are decreased because the pulmonary capillary wedge pressures, the difference between the pulmonary capillary wedge pressures and the intrapericardial pressures are reduced. So you get pulses paradoxes most characteristically in tamponade. As you know, this is a BP finding. This is a blood pressure finding rather than a pulse finding. So one thing we have to know is you have to measure blood pressure to check for pulses paradoxes. You may not be able to get it in the pulse most of the times. So this is a sign of cardiac tamponade. You might get up to 1/3 of constrictive pericarditis. Like I said, when the RV suddenly dilates and fails, also there is a restriction. There is more of interventricular dependence, so you might get it. And when there is more constriction, more pressure on the heart, like in tension pneumothorax or bronchial asthma, also you might get these same findings, but to a lesser extent. And they are absent where the interventricular dependence is not there, like in severe heart failure when the LV pressures are very high, or in severe aortic regurgitation, or atrial septal defect, as you know, because both ventricles, the septal defect does not allow one to fill more than the other. These are the three conditions when you will not get a pulses paradoxes. There is something called a reversed pulses paradoxes, when during inspiration the blood pressure increases. One easy thing to know is the positive pressure ventilation patients. If you are giving positive pressure ventilation, when the intrathoracic pressure increases, it will push more blood into the left atrium. Normally, when you inspire, the intrathoracic pressure decreases, but in a positive pressure ventilation, during inspiration, if you are increasing the pressure, more blood will go into the ventricle and that will increase the blood pressure. In isoarrhythmic AV dissociation also, when a person inspires, the sinus rate goes up, and that actually stops the AV dissociation. And when that stops, the LV starts pumping more. The atrial boost starts being effective, and then you get this reverse pulses paradoxes. You might get a reverse pulses paradoxes in HOCM also, which is difficult to explain. You can read about it. It is quite difficult to explain because basically the reverse pulses paradoxes is the interaction between the LV filling and the transthoracic pressures. This is the last slide, and I think Dr. Rajesh will also touch on it, but this is about the blood pressure square wave response. Like I said, this is one of the three manoeuvres. So one is the jugular venous pressure, the other one is the abdominojugular test, and the third one is the square wave response to Valsalva. What happens is, normally when you strain, the blood pressure is immediately transmitted to the aorta, and then because of the lesser input, as you can see, the pressure decreases here, and then there's a rebound increase in pressure. I think Dr. Rajesh will tell, but as more heart failure develops, you get this square wave response, which means it sort of increases and then stays there for a long time. So you get the square wave response. Actually, there are 5 responses to Valsalva, which indicate different phases of heart failure, and this is supposed to be a very sensitive and specific test for heart failure. Thank you. I'll hand it over now to Dr. Rajesh.
Stop share screening now. Can you see my screen now?
Yes, sir. Yeah.
I've been asked to talk about bedside maneuvers, which we commonly use in cardiology, and I'll just highlight what are the common bedside maneuvers we use. The most commonly used bedside maneuver is the Valsalva maneuver. We also depend upon isometric exercises, postural changes in then respiration, the compensatory pause following a ventricular premature complex. Also, we use pharmaceutical agents to differentiate between different murmurs or different heart sounds. The commonly used vasoactive agents are amyl nitrate and phenylephrine. The most important of these maneuvers is the Valsalva maneuver. All of you know Valsalva maneuver is a forcible exhalation against a closed airway. It was originally described as a method for inflating the Eustachian tube for pushing out infection from the middle ear. This maneuver had been used by Arab physicians dating back to the 11th century as well as by early Italian anatomists. This diagnostic use has been credited to Antonio Maria Valsalva. Not able to move my slide. The patient actually blows into a mercury manometer and maintains this 40 millimeter of mercury for 15 seconds. There's also a thing called a Valsalva equivalent. Caution is that this maneuver should There are 4 phases of Valsalva maneuver. The phase 1 is initiation. Phase 2 is the strain phase. Phase 3 is the release phase, and phase 4 is the recovery phase. So the blood pressure changes during different phases of Valsalva. During the initial phase, which is called the phase 1, there's a transient rise in blood pressure because of the increased intrathoracic pressure directly compressing the aorta. During the strain phase, the blood pressure comes back to normal, it falls, and then after the release phase, there's again a fall in blood pressure followed by an overshoot. We'll discuss each of these phases in detail as we go along. So this is a similar diagrammatic representation of the different phases of Valsalva and the accompanying changes in the blood pressure and the heart rate. As I mentioned again, there's a phase 1, there's a transient increase in blood pressure, but there's no much change in the heart rate. Phase 2 is the phase where there's a fall in blood pressure with increased compensatory increase in the heart rate because of sympathetic overstimulation, which causes tachycardia. And phase 3 is a phase where there's a fall in blood pressure without any change in the heart rate. And phase 4 is the overshoot phase, with an increase in blood pressure followed by bradycardia because of vagal stimulation. Now we'll discuss each of these phases in a little more details. Phase 1 is a phase with a transient increase in blood pressure, which lasts only for a few seconds. The heart rate doesn't change much. The mechanism, as I mentioned before, is an increased intrathoracic pressure and mechanical compression of the aorta due to the act of blowing. In phase 2, there's a reduced venous return to the atrium because of the reduced cardiac output and systolic pressure. And this causes stimulation of the carotid baroreceptors, which causes a tachycardia, and there's a peripheral vasoconstriction which follows. And phase 3 is a transient decrease in blood pressure because there's a reduction in the intrathoracic pressure. Also, there's a mechanical displacement of blood into the pulmonary vascular bed, which was under increased intrathoracic pressure, and as a result, the blood pressure decreases. And during phase 4, the accumulated venous return reaches the left ventricle, and the increased stroke volume is pumped into the constricted systemic vascular bed, causing an overshoot of blood pressure. And also, because there's an overshoot of blood pressure, is detected by the carotid sinuses, result there's onset of strain, increase in blood pressure, no change in heart rate. Phase 2, continued strain, decrease the release phase, there's a decrease in blood pressure, and there's a stable heart rate. And phase 4 is recovery, where there's an increase in blood pressure and a decrease in heart rate with bradycardia. Based on these principles, there's something which is called a Valsalva ratio, because the ratio of the longest RR interval during phase 4 to the shortest RR interval during phase 2. Because as you know, there's bradycardia during phase 4 and tachycardia during phase 2. So this ratio is taken into account. You can average the ratio from 3 attempts. This ratio reflects the integrity of the entire baroreceptor reflex arc and of sympathetic efferents to the blood vessels. Normally, the ratios are around 1.2, or more than 1.2. Less than 1.2 is considered abnormal, and it indicates that there's probably abnormal sympathetic efferents, or there's some abnormality in the sympathoreflex arc. So what are the effects of Valsalva on different murmurs? In phase 1, as the stroke volume falls, there's a decrease in the systolic murmurs of aortic stenosis, pulmonic stenosis, mitral regurgitation, and tricuspid regurgitation. The diastolic murmurs of aortic regurgitation, pulmonic regurgitation, mitral stenosis, and tricuspid stenosis also decreases. In phase 2, because of the reduction in LV volume and size, there's an increase in the systolic murmur of hypertrophic obstructive cardiomyopathy, and there's an increase in the degree of mitral valve collapse, resulting in loud and early occurrence of mid-systolic click and the late systolic murmur. In phase 3, because there's an increase in the right-sided blood flow, decrease in right-sided murmurs. In phase 4, the left-sided murmurs comes to control levels and may transiently increase. What happens in heart failure patients? As Dr. Ramachandra mentioned, patients with heart failure have an abnormal response to the Valsalva maneuver. The phase 1 and phase 3 are normal in patients' heart failure, whereas in phase 2, there's an absence of a decrease in arterial pressure tracing during phase 2. And there's an overshoot of blood pressure does not occur in phase 4 that leads to a square wave response. This square wave response is seen in patients who have very severe LV dysfunction and ejection fraction close to 20% plus minus 10%, and they're also indicative of a very high left ventricular and diastolic pressure. So why does this happen? Why does this overshoot happen, and why does this blood pressure does not fall during the strain phase? So the absence of a decrease in arterial pressure occurs due to the excess sympathetic tone to which hearts with reduced ejection fraction are subjected. And this is also partly due to excess lung blood volume in the congested lungs, which continues to empty into the LV during the entire 10 seconds of strain. So the overshoot of blood pressure does not occur in phase 4 that leads to a square wave response. This heightened sympathetic tone release does not cause overshoot of blood pressure. So based on the Korolkov sounds, in different phases of Valsalva maneuver, we can differentiate between normal and patients with heart failure. The normal patient can hear the Korolkov sounds during the initial strain phase, also during the release phase. Whereas in patients who have LV dysfunction, the ejection fraction of about 50%, and with minimal pulmonary congestion, you see the Korolkov sound, you hear the Korolkov sounds only during the initial strain phase, and you don't see it in the release phase because there's no overshoot of blood pressure in patients who have a decreased LV function. And similarly, there's a square wave response. There's no fall in blood pressure during the strain phase, and there's no overshoot of blood pressure during the release phase. So the Korolkov sounds will be heard continuously during phase 1 and phase 2, that is the strain phase of the Valsalva maneuver. So this square wave response indicates that patients have very severe LV dysfunction with an increased LV end diastolic pressure and also fluid overload. So this is a representation of the same thing. On your left-hand side is a patient who has hypertensive heart disease, and before the heart failure sets in, he has a normal response to the Valsalva maneuver. That is, there's a fall in blood pressure during the strain phase and an overshoot of blood pressure during the release phase. Whereas when he develops heart failure, there's no fall in blood pressure during the strain phase, and similarly, there's no overshoot of blood pressure during the release phase. Similarly, on the right-hand side is a patient who has atherosclerotic heart disease, a previous MI, and during heart failure, he has same response. That means his blood pressure does not fall during the strain phase, and there's no overshoot phase. But after recovery from heart failure, his blood pressure falls during the strain phase, and there's an overshoot of blood pressure. So what happens when you have a falsely abnormal absence of overshoot despite a normal LV function and no heart failure? This can happen in patients who have autonomic imbalance. Some congenital conditions can have abnormality in the autonomic response, or a patient is using a beta blocker. This can also happen in patients who have decreased blood volume, or a patient who has a moderate or large AST that can produce a square wave response. The converse of this Valsalva maneuver is a Moller's maneuver. We don't use it very often. This is a forcible inspiration while the nose is held closed and the mouth is held firmly sealed for about 10 seconds. This augments murmurs in the right side, and there will be increase in the right-sided murmurs during the Moller's maneuver. We come to the next important thing, which is the isometric hand grip. You have either you use a calibrated hand grip device, or you simply compress a tennis ball or a rolled up BP cuff continuously for 30 seconds. And you should use both hands simultaneously. So what does this hand grip cause? It increases systemic vascular resistance, it increases the arterial pressure, it increases the heart rate, it increases cardiac output, it also increases the left ventricular filling pressures. So what happens to the heart sounds? The left ventricular third out sound and fourth out sound is increased, the aortic stenotic murmur is decreased, the aortic regurgitation murmur is increased, the mitral regurgitation murmur is increased because of increased afterload, and similarly the ventricular septal defect murmur is also increased. The mitral stenotic murmur is increased because of increased cardiac output, the HOC murmur decreases, and the click and late systolic murmur or mitral valve prolapse are delayed because of increased LV volume. Mind you, the HOC murmur and the mitral valve prolapse murmurs depends upon the LV volume. So if you have increased LV volume, the murmur of HOCM will increase, and the MVP murmur will be delayed with the late appearance of the systolic click. So then after the isometric hand grip exercises, we move to the postural changes and how it can impact your murmurs and heart sounds. So first thing is a sudden passive elevation of legs. or a sudden assumption of lying from standing or sitting position. So what does this do? When you passively elevate the legs or you suddenly assume a lying posture from standing position, you increase the venous return, increase the RV stroke volume, and following several cardiac cycles, there's an increase in LV stroke volume also. So what happens to the heart sounds and murmurs during passive elevation of legs? Because there's an increased venous return, there's a widening or splitting of second arch sound in all phases of respiration. The right ventricular third arch sound, fourth arch sound, and several cardiac cycles later, the left ventricular third arch sound and fourth arch sounds are also increased in intensity. The pulmonic stenotic murmur, the aortic stenotic murmur, the mitral regurgitation murmur, the tricuspid regurgitation murmur, and the ventricular septal defect murmur, the systolic murmurs are increased. The functional systolic murmurs are increased. The HOCM murmur is reduced because of increased LV and diastolic volume. The click and late systolic murmurs or mitral prolapse are delayed and sometimes attenuated. Then we come to the reduction in venous return, which happens when you rapidly stand from a sitting position or a lying position, or you assume a squatting posture. So what happens? There's a decrease in venous return. There's a splitting of second arch sound is reduced. The aortic stenotic murmur is reduced. The pulmonic stenotic murmur is reduced. Mitral regurgitation murmur is reduced. Tricuspid regurgitation murmur is reduced. And because of a small LV cavity, HOC murmur is increased in intensity. And also there's a mitral prolapse murmur is increased in duration. The click happens earlier and because of a small left ventricle. So what happens then? We come to squatting. Squatting is a very important maneuver we use at the bedside to differentiate between different murmurs. So the principle of squatting is it increases venous return because of compression of the calf veins. It increases stroke volume. Similarly, there's an increase in systemic vascular resistance because of kinking of the femoral arteries. The increased arterial pressure causes transient reflex bradycardia. So what happens in squatting? The third arch sound and fourth arch sound from both ventricles are increased in intensity. The pulmonic stenotic murmur is increased. The aortic stenotic murmur is increased in intensity. The tricuspid stenotic and mitral stenotic murmurs increase, all because of increased stroke volume which happens during squatting. Similarly, squatting is a compensatory mechanism in tetralogy of Fallot. So what happens in squatting in a Fallot RVOT murmur? The RVOT murmurs increase in intensity because of increased afterload in the aorta, and the mitral regurgitation murmurs increased, the ventricular septal defect murmurs increased, and the aortic regurgitation murmurs increased. Similarly, the elevated arterial pressure and the increased venous return increases the LV size, reduces the obstruction to outflow tract, and decreases the murmur of HOCM. The click and late systolic murmur of mitral prolapse is delayed. So this is a chart which shows the differentiation of different murmurs based on the posture and in squatting. What are the murmurs which increase on upright posture? There is a hypertrophic cardiomyopathy and the mitral prolapse murmur which happens earlier and the murmur is longer. Whereas murmurs which are softer on the upright posture are aortic stenotic murmur and the pulmonic stenotic murmur. Murmurs which are louder on squatting are the aortic regurgitation murmur, the mitral regurgitation murmur, the ventricular septal defect murmur, pulmonic stenotic murmur, aortic stenotic murmur, and the tricuspid regurgitation murmur. Murmurs which are softer on squatting are hypertrophic obstructive cardiomyopathy murmurs and the murmur of mitral valve prolapse. Then we come to another maneuver is changing the position of the patient to a left lateral decubitus position. This increases the cardiac output. As a result, the third arch sound and fourth arch sound on the left side is increased. The opening snap and the mitral stenotic murmur and the mitral regurgitation murmurs are increased. The click and late systolic murmur of mitral prolapse is increased, and the ostensibly murmur is also increased. So when you sit up and ask the patient to lean forward, all the regurgitant murmurs, predominantly the aortic regurgitation murmur and the pulmonic regurgitation murmurs, are increased in intensity. Then we come to the different phases of respiration and how it changes your the intensity of heart sounds in the murmurs. We come to inspiration first. Inspiration causes an increase in systemic venous return due to a fall in intrathoracic pressure. The RV stroke volume is increased. The duration of RV ejection is increased. There's reduced pulmonary vascular impedance, and the pulmonary hangout interval is increased to more than 80 milliseconds. Simultaneously, inspiration also causes a decrease in pulmonary venous return due to pooling of blood in the pulmonary vasculature. There's reduced LV stroke volume and LV ejection, and there's the reduced hangout interval on the aortic side. So along with the reduced hangout interval on the aortic side, there's an increase in the hangout interval in the pulmonic side. As a result, the second heart sound is normally split during inspiration, while during expiration is heard as a single sound. The third heart sound, fourth heart sound, the opening snap, and the right ventricular third heart sound and fourth heart sound, the right-sided opening snaps are increased in intensity with increased RV stroke volume during inspiration. The left-sided sounds are reduced in intensity. Whereas the pulmonary ejection sounds, the only right-sided ejection sound which is decreased during inspiration is a pulmonary ejection sound. Why the pulmonary ejection sound is decreased in inspiration is because there's an increased venous return to the right side, the RV stroke volume is increased, simultaneously there's an increase in RV and diastolic pressure beyond the pulmonary artery diastolic pressure. As a result, there's premature opening of the pulmonary valve in diastole itself and less upward motion of the valve leaflets, causing a reduced intensity of the pulmonary ejection sound. The aortic ejection sound usually does not change with inspiration. What about the effects on heart murmurs on inspiration? All right-sided murmurs increase during inspiration because of the increased RV stroke volume and vice versa. What happens to the mitral valve prolapse murmur? This is louder and early occurrence of mid-systolic click on inspiration and murmur during systole as a result of reduced LV stroke volume and reduced LV size, which increases the degree of valvular prolapse. There's no change in the inspiratory augmentation of heart sounds and murmurs in patients with right-sided heart failure because of increased right ventricular and diastolic pressure. So this is again a summary of what happens during inspiration, expiration of different heart sounds and murmurs. On your left, you have expiration. The left ventricular third heart sound and fourth heart sounds are increased. The mitral regurgitation murmurs increase. Mitral stenotic murmurs increase. Aortic stenotic murmurs increase. The aortic regurgitation murmurs increased. Whereas on the right hand side, you have right ventricular third and fourth heart sounds with increase on inspiration. The tricuspid regurgitation murmurs increase on inspiration. The tricuspid stenosis, pulmonic stenosis, and pulmonary regurgitation are also increased on inspiration. So in patients who have pulmonary hypertension and right heart failure, there will be little or no increase in the venous return to the right heart with inspiration because of very high right ventricular and diastolic filling pressure. And so in pulmonary hypertension and right-sided heart failure, there may not be a demonstrable inspiratory augmentation of right-sided murmurs and heart sounds. Let me come to a pharmacological maneuver which is commonly used. I don't think it's being amyl nitrate is available in India, but this has been described in textbooks. Amyl nitrate is a predominant arterial vasodilator. How is it done? You use it's available in an ampule form. This is held near the patient's nose, and the ampule is crushed. The patient is asked to take 3 to 4 breaths over 10 to 15 seconds. In the first 30 seconds, there's marked vasodilatation, reduced systemic arterial pressure, and 30 to 60 seconds later, there's a reflex tachycardia. And this followed in turn by a reflex increase in cardiac output, the velocity of blood flow, and the heart rate is also increased. So what happens when you inhale amyl nitrate? The first heart sound is increased in intensity. The aortic second sound is decreased in intensity. The opening snap of mitral stenosis and tricuspid stenosis are increased in intensity. The A2 opening snap interval is reduced because of a reduction in LV and diastolic pressure. And the third heart sound from either ventricle is increased. And what happens to the aortic stenotic murmur? It is increased in intensity during when you inhale amyl nitrate. The pulmonary stenotic murmur is increased. HOC murmurs increase intensity. The tricuspid regurgitation murmurs increase in intensity. And all functional systolic murmurs are increased in intensity. What happens when you give or inhale amyl nitrate in a patient with tetralogy of Fallot? There's a reduction in arterial pressure. There's an increase in the right to left shunt, and there's a decrease in blood flow from the right ventricle to the pulmonary artery. As a result, the systolic murmur of RV outflow tract is reduced in patients with tetralogy of Fallot. And amyl nitrate actually causes An increase in the cardiac output, and this causes the mitral stenotic murmur, the tricuspid stenotic murmur, and tricuspid regurgitation murmur to increase in intensity. The pulmonary regurgitation murmur is also increased, and the isomental pulmonary regurgitation murmur is decreased when you inhale amyl nitrate. Similarly, amyl nitrate also causes a fall in the reduced intensity of mitral regurgitation murmur, reduced intensity of ventricular septal defect murmur, the aortic regurgitation murmurs reduced intensity, the Austin-Flynn murmurs reduced intensity, the murmur of PDA is also reduced. Similarly, the systemic AV fistula murmurs also reduced in intensity. All this happens because of the fall in systemic arterial pressure. So what happens in a patient mitral prolapse? There's a reduction in cardiac size, and there's an early appearance of mid-systolic click and late systolic murmur of mitral prolapse. The intensity of systolic murmur exhibits a variable response with amyl nitrate. So amyl nitrate is very useful in distinguishing aortic stenotic murmur from mitral regurgitation murmur. When you have a systolic murmur in the left upper cell border and you want to differentiate aortic stenotic murmur from mitral regurgitation murmur, this is a very useful maneuver. The aortic stenotic murmur increases in intensity, whereas the mitral regurgitation murmur reduces the intensity. Similarly, if you want to differentiate a tricuspid regurgitation murmur from a mitral regurgitation murmur, the tricuspid regurgitation murmur increases during amyl nitrate, whereas the mitral regurgitation murmur reduces during amyl nitrate inhalation. How to differentiate isolated pulmonic stenosis from tetralogy of Fallot? The isolated pulmonary stenotic murmur will increase in intensity, whereas the TOF murmur will reduce in intensity with amyl nitrate. And how will you differentiate a mid-diastolic murmur of MS from an Austin-Flynn murmur? Amyl nitrate will cause mitral stenotic murmur to increase in intensity, whereas Austin-Flynn murmur will reduce in intensity. The pulmonary regurgitation murmur will increase in intensity, whereas aortic regurgitation murmur will reduce in intensity with amyl nitrate. Exactly contrasting amyl nitrate is what is phenylephrine. Phenylephrine produces an effect opposite to that of amyl nitrate. It increases systemic arterial pressure, it causes reflex bradycardia, decreases the contractility, and also decreases cardiac output. So we give 0.3 to 0.5 milligram of phenylephrine intravenously. It elevates the systolic pressure by 30 millimeter mercury for only 3 to 5 minutes, and it should not be used in patients with heart failure and increased blood pressure. So the phenylephrine causes the S1 murmur to be reduced in intensity. The A2 opening snap interval is prolonged because of an increase in LV and diastolic pressure. The aortic regurgitation murmur is increased. Austin-Flynn murmur is increased. The mitral regurgitation murmur is increased. The VSD murmur is increased. The TOF murmur is increased in intensity, and the PDA murmur is increased in intensity. Similarly, a systemic AV fistula murmur is increased. HOCM murmur is reduced because of a increased left ventricular size. The click and late systolic murmur of mitral prolapse is also delayed. So phenylephrine it causes the murmur of aortic stenotic murmur to be reduced in intensity, the functional systolic murmur is reduced in intensity, and the mitral stenotic murmur to be reduced in intensity, all because of a reduction in cardiac output. So this chart summarizes the differences in murmurs based on different pharmacological agents which you give. On the amyl nitrate causes systolic murmurs. I will not enumerate each of this. Already discussed in detail in the previous slides. So what happens to the murmurs when the change in cardiac cycle, either because of a compensatory pause following a ventricular premature complex or a long cycle length in atrial fibrillation? So because of this increased compensatory pause, there's increased ventricular filling, there's increased ventricular contractility of the next beat. This increases the intensity of murmurs that are caused by obstruction to either left or right ventricular ejection. Regurgitated murmurs of the valves do not change appreciably following a compensatory pause. The aortic stenotic murmur and the pulmonic stenotic murmur accentuate due to increased ventricular filling and it causes a prolonged preceding diastole and increased LV contractility. What happens is systolic murmur of HOCM? This is increased because due to increased LVOT obstruction as a result of increased ventricular contractility associated with a decreased volume of the pulse. This is called the Brockenborough-Braunwald-Morrow sign. Then the mid-systolic click and the late systolic murmur of mitral prolapse are delayed because the prolapse is reduced due to increase in ventricular filling and the LV size is reduced. So based on the cycle length, we can differentiate the murmur aortic stenotic murmur from a mitral regurgitation murmur. The aortic stenotic murmur will increase in intensity, whereas mitral regurgitation murmur will not change with increased cycle length. The pulmonic stenotic murmur will increase with longer cycle length, whereas aortic regurgitation murmur will not change. HOCM murmur will increase with following a longer cycle length. Then this hepatojugular reflex, Dr. Ramachandra has discussed in detail. I'll not go into details of this. And Kussmaul sign also he has discussed. There's a rise in the height of jugular venous pulsations during inspiration. This is seen in restrictive cardiomyopathy. 1/3 of patients with constrictive pericarditis, patients having right ventricular myocardial infarction, right heart failure, and massive pulmonary embolism and tricuspid stenosis. The mechanism is already explained. And then the pulsus paradoxus also he has discussed. This was described by Antonio Kussmaul in the late 1800s. Why it is called pulsus paradoxus? Because the person who described it noticed that the apex beat was good, but there was a fall in radial pulse during inspiration. This is a marked fall in systolic pressure during inspiration is what is called pulsus paradoxus. And this is seen in pericardial tamponade, constrictive pericarditis, emphysema, asthma, marked obesity, and severe congestive heart failure. You can have false negatives in patients with tamponade. We have severe aortic regurgitation. There will be fills during inspiration. There will be no fall in the pressure during inspiration. Similarly, in circulatory hypovolemia, in tamponade also there will be no fall in pressure during inspiration. So this is, I just want to conclude by saying that this important maneuvers can be used to differentiate between different heart sounds and different disease conditions in your bedside. And thanks for your patient hearing.
So, hope you can hear me.
Yeah, but I can't see you. I think Dr. Rajesh has to.
Okay.
Can you stop sharing the screen, please?
Yes, sir.
Yeah. You can stop sharing the screen, Dr. Rajesh.
Yeah.
So in about 1 hour, 15 minutes, both of them together have wonderfully covered clinical cardiology. I think all those who have a recording of this should revise this at least monthly, once or twice, so that the clinical examination becomes easy. Also, it is important that whenever we make a clinical diagnosis, the most dominant lesion or the final diagnosis with severe form should tally well with the pulse and the JVP. And for DM, DNB cardiology exams, there will invariably be cases like restrictive cardiomyopathy or constrictive pericarditis kept if the patient is available. And unless you are meticulous with JVP examination, it is very easy to miss it. So also, like Dr. Rajesh explained, it is very important that we add on the dynamic auscultation, most commonly the isometric hand grip, and also the squatting standing position variation in murmur for confirmation of the diagnosis. And please do not diagnose severe hypertrophic obstructive cardiomyopathy without an additional dynamic auscultation findings. We'll go to the doubts one by one. Now, first question is, how will we differentiate between mitral regurgitation and Austin Flynn murmur? From Dr. Tushar. One of you can answer.
You can take it, Dr. Tom.
Yeah.
Would you like to talk about it, Dr. Rajesh?
Yeah, Austin Flynn murmur, when you give amyl nitrate inhalation, because of it's a predominant arterial vasodilator, so the aortic regurgitation murmur will actually reduce in intensity, whereas the mitral regurgitation murmur will also reduce in intensity. But how will you differentiate MR from Austin Flynn? I really don't know.
Yeah, I think there is something wrong with the question. Now, usual question is we want an Austin Flynn murmur in diastole and we want to differentiate it from another diastolic murmur. The question was mitral regurgitation. So mitral regurgitation is systolic murmur, so there is no question about differentiating mitral regurgitation from one is systole and one is diastole. I think the questionnaire wanted to know how to differentiate between an Austin Flynn murmur and an MS murmur.
Yeah,
so both are diastolic murmurs, and like he said, it's a very good classical example of how amyl nitrate can induce tachycardia and vasodilatation, which can actually increase the mitral stenosis murmur and reduce the Austin Flynn murmur because the AR comes down.
Anything that reduces aortic regurgitation will decrease the diastolic murmur and make it happen earlier. So basically, any maneuver that decreases the aortic regurgitation. Is that right, Dr. Rajesh?
Yeah, I think you're right.
Do you have any other questions?
No, there are no other questions.
Yeah. So far, no further questions, sir.
Okay. Yeah.
So let me conclude, sir. Yeah. So we are now towards concluding this wonderful program. I must say this, it was an exciting program which has enabled us to gain from the wisdom and expertise of the speakers and panelists. I take this opportunity to thank Dr. Devaasia, Dr. V.S. Ramachandra and Dr. Rajesh T for their great contribution in making this program possible and successful. I am thankful to all participants who have taken time out of their busy schedule to attend this program. I thank all of you for making this event a successful one, and I sincerely hope your support will remain with Torrent in times to come. Thank you, goodbye and good night to all, sir.
Thank you, Shantanu, and thanks Torrent for this meeting. Thank you.
Thank you, sir. Thank you, sir.
Thank you. Good night, all.
Sridhar also. Yeah, thank you, Sridhar.
Thank you, sir. Thank you, Dr. Ramachandran. Thank you, Dr. Rajesh. Thank you, Dr. Tom.